Thank you very much for the warm welcome. This morning when I was at the airport, I quickly looked up the program and saw it said Dr. David Rosengren, Visionary Healthcare something. And I thought to myself, oh my God. And I did spend some time on the aircraft thinking to myself, visionary. And I had images of shimmering lights and halos. But I'm delighted that when I actually got here and read the program that had been corrected and it was just David Rosengren, emergency physician. So the pressure is significantly reduced in that short period of time. You may wonder why an emergency medicine physician from Brisbane would have anything to talk about at a primary health conference in North Queensland. And so I guess the reason that I'm really here is in my role as the chair of the Queensland Clinical Senate. And there are a few familiar faces in the room, so I know that there are some people here who will know a little bit about the Senate. But there's nothing worse than sitting in a room, hearing a conversation about something that you don't quite understand the context. So for those of you who don't know, the Senate is a representative group of clinicians across Queensland with the responsibility of providing strategic advice to the department and to the minister on health policy. It is a state health organisation, so it is predominantly focusing on state-funded issues. The membership, which is quite broad and diverse, consists of medical, nursing and allied health. It is a true multidisciplinary representative body. Every one of the 17 health services across Queensland has representation. But it is more than that, and I'm delighted that we also have representation from primary care. We have a very strong consumer representation. And although the PHNs are not members of the Clinical Senate per se, we have had very strong representation from the PHNs who have been invited to every one of our Senate meetings since the PHN organisations came to exist. We've heard a lot of presentations already in the short start to the conference that identify that there's a lot of challenges that lie ahead of us. But I'm going to challenge you a little bit, what are we so worried about? We're extraordinarily fortunate in Australia to have one of the best health systems in the world. Our life expectancy as Australians is up there amongst the very best. The preventable death rate of Australians is up there amongst the very best in the world. We achieve our extraordinarily health outcomes with a very small proportion of our total GDP in relationship to our fellow OECD countries. A quick sneak preview: every few years, the Queensland Government Chief Health Officer releases a report that outlines and maps out the health of Queenslanders. This report that will be released later on this year will identify that we are actually doing pretty well. Over the last decade, our life expectancy in Queensland has increased by 2 years. We have a healthier lifestyle, we've reduced our cigarette smoking, we've increased physical activity, and in fact there are suggestions that the growing epidemic on obesity is beginning to plateau out. We have made some small but significant improvements in closing the gap in Indigenous health outcomes across our state as well. So there's a lot of positivity, but I am not completely ignorant and silly. We do recognise, and in fact all of our speakers before me this afternoon have identified everything that you already know. Queensland has enormous geographical, ethnic and community diversity. We have a very complex dual-funded health system, and we have this complexity of relationship between our primary and acute care systems. We are actually very fortunate in Queensland. We are unique from the other jurisdictions in that of our PHNs, 50% of our PHNs have got a co-governance arrangement with their health services. And this will be a very unique opportunity to actually identify the impacts of actually having a very close relationship where the hospital and health services tended for and were successful in the strong involvement in the running of the primary health networks. So why integrated care? Why would the Queensland Clinical Senate be interested? Currently, if you have a look, over half of our Queenslanders over the age of 65 have a chronic disease, with 20% of Queenslanders having more than one. We all know the statistic that is only going to increase over time, and unless we take some strategic steps towards trying to tackle that, we're going to find ourselves with an ever-increasing problem. But in reality, isn't this a primary care issue? So why would an organisation called the Queensland Clinical Senate, which is responsible for providing advice around acute hospital services, have an interest in this whole concept of integrated care? And the reason for that is pretty obvious, and I hope that I don't have to explain it in too much detail. We have an ageing population, we have a shrinking workforce, we have increased chronic disease, we have a huge increase in demand on our health service that far outstrips our population growth. We have an increase in complexity of technology and delivery around our healthcare system, so it becomes so much more costly to deliver the same sort of care now as it did a decade ago. And anyone that hasn't been hiding under a rock for the last few months is going to realise that the future cost sustainability of our health system is a major challenge in the political arena. And everywhere you go, people tell us we can't continue to afford to deliver healthcare the same way we do now into the future with that growing collection of challenges that we're facing. So the concept of the management of chronic disease and keeping our community healthy is not just a problem of primary care. It is a problem for the entire healthcare system. And that is why the Queensland Clinical Senate decided to take on this challenge of integrated care. I'll just go back one step. In fact, the Minister didn't really allude to this in too much detail, but at the recent state budget, a record $153 billion, sorry, I'm going to lie, a record $15.3 billion from the Queensland state budget was allocated towards health. That's 29% of the total state government expenditure on our health service. Over the last decade, the amount of money we have spent on our acute hospital care has increased by 65%. We can't continue to go down that trajectory. Over the last, in fact in 2014, 2015, on average, 1 in every 5 Queenslanders had a hospital admission. And the average hospital admission costs over $12,500. You can fit in a lot of general practice and primary care consultations for $12,500. So there's great advantages and great motivation for us to try and reshift the focus of delivering of care out of the high-cost hospital system back into primary care where patient care needs to be centred. So the Senate question was, how can acute and primary care work together and with consumers to improve connectivity and make the healthcare experience better for our patients who are living with chronic disease? And so that was the challenge that we decided to take on in October last year when the Senate came together. And in fact, that challenge actually started about 18 months beforehand, because the concept of a Senate meeting on integrated care had been talked about for, in fact, almost 2 years, but it was such a complex and wicked problem that we never quite had the courage to do it. And we finally succumbed late last year. And we were fortunate to have a very diverse and very talented collection of speakers and presenters at that meeting. In particular, there was a comment from Martin Bowles, who was the Secretary for the Commonwealth Department of Health. And you'll have to forgive my very bland slides. For some reason, all of my formatting's disappeared and all I've got my text, so I am more creative, but all you've got is white and black, I'm sorry. And what Martin Bowles said was, he's the senior officer responsible for the delivery of Commonwealth Health Services, and his comment was, we need leadership across all parts of the health system if we are to start to connect all of the fragmented and disconnected parts that we see. And I think that's a really true comment, but I don't think it's a particularly surprising comment, and I'd be very surprised if it was new to any of you who are here in the room today, really. So as clinicians and consumers, what can we do? I mean, you know, we're small players in this game. The governments fund and purchase healthcare, and our health services sell care. There's always a but as clinicians, we're the ones that actually deliver the care. And as consumers, we're the ones that rely on that care and receive that care, and very importantly, we're the ones that judge the performance of the system. And I think that I don't have a lot to tell you around a curriculum in primary care, so you can put your pens and your pencils away and not have to worry about taking notes. What I can hopefully is describe a story and experience around how clinician and consumer engagement and involvement can actually play an important role in changing the way things happen at those levels that seem to be above and beyond us at times. And the importance of consumer involvement, I think, was very nicely summarised by one of the consumers that spoke very vividly about their experiences at our meeting. And this particular consumer said, "I want to be central to my own health issues." Most people tend to forget that I'm the one that you need to discuss things with. How often are we engaging the consumers that receive our healthcare into the discussions that we're having about the healthcare that we want to deliver on their behalf? And I think that if you go back through history, you will find that we've been very poor at doing that, and that we haven't done that in any way as well as we need to. And I'm pretty sure that there's currently some political parties at a Commonwealth level who are regretting some of this strategy when it comes to healthcare policy at a national level. So there's no questions that we need to have a major shift. We need to shift from the traditional role that says that, we're the clinicians and we provide care to our patients. We'll tell them where they can come to and at what time they can come and who they can see. I think as we move forward over the next decade, there's going to be a really significant shift towards a dynamic system that is more patient-centred. We had a great opportunity at our meeting in October last year to hear from some true visionary healthcare leaders, including David Mates, who some of you may know, who's the Chief Executive from Canterbury Health Services in New Zealand, Scott McLaughlin, who's the Chief Exec of the Western New South Wales LHN, and also from a few other speakers that some of them who I know are going to be on our program for tomorrow as well, that you'll get to have an opportunity to hear too. And they had some really valuable lessons for us. And again, none of this is new, but it just reinforces that we know what we know. And sometimes it's really good, I think, to be reassured by people who are trying to solve the same problems in other areas, to find that the problems that they're struggling with are the same as the problems that we are struggling with, and that the solutions that they're finding probably are particularly relevant to us. And some of the take-home messages that I think came out of our very strong discussions at that time: integration needs to be driven locally, not centrally. We need local leadership to reflect the local circumstances. And that's why this conversation around the North Queensland PHN is really important, about trying to identify what the local solutions are to our local environment and our local population. The system, the minister, the government, the department, whatever they might be, their responsibility is to support and embrace and encourage the spread of innovation and the sharing of ideas. But the solutions need to come from within our local communities. And the PHNs have provided a huge opportunity for that to be realised into action. Very, very importantly, and again, this is critical at both a PHN and a hospital and health service level, we need to engage with our clinicians and work with the willing. We need to identify who our local champions are, and we need to do everything in our power to give them a voice and to lift them up and to elevate them so they have an opportunity to be able to influence and to be able to engage with and bring their colleagues along with the journey. The local networks that you belong to and that you work within and that you exist amongst are by far the most overwhelmingly powerful tool for change that exists. So to engage within your PHN, to work with your colleagues in your local practices and your local community, is far more effective at driving change than anything that any organisation at a government level can produce or try and provide. And I think you need to be able to remember that it's your local networks that will really be the solutions to many of the complex problems. And very importantly, and I think David Mates from Canterbury really highlighted this, and it's something that as an individual I hadn't really reflected on as much as I should be, is that we talk about all sorts of measures of effectiveness about what we do, But he challenged us that, in fact, one of the most important was actually patients' time. And how often do we think about how well are we using our patients' time when we decide about the healthcare that we provide to them? And from an acute hospital point of view, am I using my patients' time well when I bring them back on Monday to see their endocrinologist, I bring them back on Wednesday to see their cardiologist, I bring them back on Friday to see their renal physician, and I bring them back in 3 months' time to see their neurologist? Am I using their time very wisely when I see them on one day, but then organising their scan for 3 weeks' time, and then I'll bring them back in another 2 weeks' time to chase up the results? In primary care, do we take into consideration how we utilise our patients' time in the way we refer them on for services or the way we provide them care? And in fact, it's such a simple principle that it's one that I'd never thought of, and it certainly has changed my attitude as a clinician to some of the decision-making that we make. And from a providing care across the primary and the acute hospital interface, how good are we at considering how we're using our patients' time in deciding who, how and where we manage our patients across the complex health system within which we operate? Something simple, but something worth thinking about. And the other really important challenge for consumers and for our entire community is that we need to start to work to support people to start taking more responsibility for their own healthcare. And I think that is going to be a real shift in the way we approach the delivery of healthcare, is that as primary care clinicians in particular, we need to start to encourage and support our patients to become far more responsible in managing their healthcare and being far less dependent on the system. The Minister alluded to that a lot when he described the huge increase in demand for emergency department sort of care in our lower acuity categories over the last decade. We need to start to encourage patients and change that culture around patients being more responsible, managing their health more proactively, and engaging with primary healthcare as a far more active and mainstream supplier of their healthcare services. So from the Senate point of view, a lot of lovely conversations, lots of high-level conversations, lots of motherhood statements, but what are we actually going to do with that with regards to driving some change? And so what we actually did, and in fact I think it was probably the first time that this had happened for many of them, is we brought together senior clinicians and executives from our hospital services and for our PHNs, and we sat them all in the room together for a day. And what became really apparent was that there was a very mixed level of sophistication in relationship between our PHNs and our HHSs. And for some of them, it was the first time they'd actually met and actually had one-on-one conversations. And so what we did was we brought everyone together in the room together, and we challenged them around the higher level concepts about how do we work together around shared governance of healthcare. We were never going to solve integration of care in one day and come to the solution of all our major problems. But what we wanted to do was to take a macro level approach about how do we work together at a high level around planning our healthcare services into the future. And some of you, in fact I hope many of you might be familiar with the body of work that was done. This was published about in 2014, I think, done by Carolyn Nicholson and Claire Jackson and published in the MJA. And it was a body of work that did an extensive literature review looking at what are the elements around governance of integrated care that are essential for success. And we challenged our clinicians and our executives from our system to actually work through, this paper identifies 10 key elements, and I'm not going to bore you to death with the details of that. For those with the interest, you can chase down that article and have a read of it. But what we did was we went through a deliberate process of conversation and discussion in a collective environment around, as a HHS and a PHN, how do we relate to these 10 key priorities and principles, and what can we start to do about those proactively in moving forward? And all of them are very relevant and very important, but the three that seem to really resonate on that particular day for our Queensland clinicians and execs was this concept of joint planning and governance, access to good quality data to create a burning platform for change. We've we're so data rich, but we are so data poor. We don't get good quality data that actually helps us decide what we're going to do. But it's nice to see that, for example, in North Queensland, this conversation about doing a needs analysis and starting to really get some good quality data about our local community that can help to drive some of our policy decision making. And we need to sort of work on building some partnerships, identifying champions for change. The champions lie within our clinical and consumer workforce. We've just got to find out who they are, and I'm pretty sure that every one of you here today is a clinical champion for, good quality integrated care and connecting across the system, because that's why you're here on a Saturday afternoon. So each one of you is a local champion to start to drive change. And what the Senate recognised in this very lengthy conversation over a long day's work is that this is not anyone's challenge, but in fact it's everyone's challenge. And really what the Senate identified was a number of recommendations, which is what the Senate's responsibility is to do, is to identify a complex problem and try and identify some challenges or some recommendations for the system to try and tackle and implement as part of its problem solving moving forward. And the first set of challenges or recommendations was actually to our consumers, to our community. And it's one of the strengths of the Clinical Senate is that we have a very strong consumer involvement and engagement through Health Consumers Queensland. And very often, in fact, in most of the work that we do, an element of the recommendations is challenges out to the community and the consumer organisations to take some responsibility for being involved. So we challenge our consumer organisations to actively partner with the health services around integrating care and to be constructive contributors to that. To assist in the development of strategies to enable effective consumer participation in their own care and in co-designing integrated models of care. Within your local health services and your PHN structures, how strong is your consumer involvement in providing direction on where your investment should be and where your strategy should lie? I think already that's been outlined that you've got some good consumer councils and some good consumer engagement. And in fact, I think it was already described that there's a collaborative group across both your PHN and your HHS providing some consumer advice. But I think that's critical moving forward. And history will suggest that's the case. The Senate challenged primary health networks and hospital and health services to commit to collaborative governance with a shared vision and a single strategy. It sounds really simple. But in fact, as we sat around the tables having this conversation, you could see these nervous glances across the table amongst everyone thinking, that sounds lovely, but what the hell does that mean? We challenged the PHNs and the HHSs to be more consumer focused with regards to their integrated models of care and to support clinical champions to create opportunities for shared learnings. That's exactly what today is, isn't it? The first ever PHN conference, an opportunity to share experiences and to have those conversations. And this meeting of the Queensland Clinical Senate was in October last year, and just as an example, I received an email. One of my jobs is as a clinician at the Royal Brisbane and Women's Hospital, that's Metro North, $2 billion health service. And this photograph and an email accompanying it landed in my inbox on October the 31st, about 3 weeks after we'd had our Senate meeting. And what it is, it's a photograph of the executive team of the PHN and the HHS signing a memorandum of understanding around shared governance and around shared strategies towards deliver healthcare in the largest budget health service in Queensland. And I thought, good on you. And there are a number of very bold statements that came with that. This partnership focuses on the complete patient journey through a model of integrated care which positions both organisations to provide seamless quality care. What a beautiful motherhood statement. Love it. We share a vision to have a community where good health is available to everyone, and through partnerships we can make this happen. Beautiful language, beautiful use of the English language. Cross-sector collaboration is essential to maximise patient outcomes and is a big win for everyone. So we have a PHN and a HHS that have come together and publicly signed an agreement that commits to these values. So they've just started their journey, now they've actually got to deliver on that. But as the last 12 months has unfolded, More and more and more, we are now seeing these public declarations of commitment to shared governance between our PHNs and our HHSs. And I think that by starting the conversation, by clinicians engaging with executives across the dual-funded health system, we have seen in a short period of time some really positive connection at a senior governance level between our PHNs and our HHSs. And from what I've seen and heard in the brief presentations we've had this morning, that North Queensland has made a big step in the right direction towards that collaborative governance and that shared commitment to what our strategies and our priorities have to be moving forward with regards to delivering healthcare services. So every now and then, I think we can start a conversation that can lead to some change, and I think there's some real positivity there. The Senate went on to challenge the Department of Health to support sharing of information. And the Minister's already alluded to that when he was here earlier around this concept of GP access to the viewer. He was very polite. He didn't swear about me or the Queensland Clinical Senate and the persistent badgering that we have provided to the government and the department. Something so simple, low-hanging fruit, so easy, just flick a switch. For those of you who don't know the viewer is the simple but incredibly useful tool that allows us within the acute hospital system to bring together the clinical care received or delivered to patients across all of our hospitals in Queensland. So I don't have to get on the bloody phone and ring my hospital 7 kilometres down the road and sign a consent form and fax it off and wait 3 hours for them to send me the notes of the patient who presented to the ED yesterday at Prince Charles when I'm at Royal Brisbane. I can just log on to the viewer and I can see it. So we share discharge summaries, pathology, radiology. Soon we can actually be able to visualise the images as well amongst all the clinicians that work in the hospital for the patient. But bloody hell, do we hide it from our primary care clinicians? Of course we do. Under no circumstances would we let you see any of that or share that. Why would we? And so we have lobbied furiously as a result of these conversations and very successfully. And I really hope that by this time next year, at least widespread across the state, primary care clinicians sitting in their GP practices will be able to log on to the viewer through a secure portal and be able to access the clinical information that's relevant to them about their patient's hospital care. So when the patient arrives in your GP surgery after being discharged from the hospital 2 days ago, you'll be able to see what their discharge medications were or what the results of their ultrasound was or their CT scan or whatever. Oh my God, the health savings and the efficiency and the quality improvements that our patients will get as a result of something so simple is so overwhelming. So we do make success every now and then. We've convinced the Minister to change legislation that's currently before Parliament around changing legislation to open this information up. That's a huge success for clinician-led advocacy for patient care. The other thing is that we challenge the government around developing and embedding flexible funding models and financial incentives to encourage collaboration and work across the two sectors. And you've got to remember the state government's responsible for funding hospital services predominantly. The Commonwealth's responsible for funding primary care. That's someone else's. That's been the game for the last 3 decades. It's someone else's responsibility. And following our integrated care meeting, this is what the Minister alluded to, the Integrated Care Innovation Fund, $35 million over 2 years to fund collaborative programs around integrated care between primary care and hospital care. And so there are a bunch of criteria that were laid out with very little time for the health services and the PHNs to get together over this. But what they wanted to do, and before I go into that very briefly, this is a big government commitment. This was a highlight of the recent government's budget announcements. The $35 million Integrated Care Innovation Fund is a key state government commitment in the most recent budget. It's not an insignificant announcement by the Minister, and again, this is in response to the clinician-led and health service-supported conversations. And so health services were asked to, put together these proposals, and they had a number of criteria. They had to demonstrate innovation, strategic alignment, value, partnership, and they also had to demonstrate sustainability and scalability. There are 17 health services across Queensland and there's 7 PHNs. Every single one of those is represented in the 62 submissions that were put forward to round one for $130 million worth of funding. And what that demonstrates is this latent capability and a latent demand for this sort of initiative. The first round of those, or successful round, will actually be announced hopefully in the next couple of weeks by the Minister. And there will be a second round. The first round has provided this really valuable opportunity. What it's done is it's brought everything to a central place. So all of the HHSs and PHNs around the state have collaborated together, and now we have this pool of shared ideas. And not all of those will be funded, but what we'll be able to do is go back to those PHNs and HHSs that had really similar ideas and link them together, so that instead of having 60 submissions, we might be able to bring them together as collective. So for the first time, we've been able to bring together the ideas from across the entire state around integrated care, and we'll be able to fine-tune those and finesse those so that when round 2 bids come into action, which will hopefully be in about November this year, that the quality and the fundability of those projects will have increased significantly. So as I said, this has been a really exciting initiative. And the other strength about this is that the selection process has involved very senior representation from the Commonwealth, very senior representation from local Queensland clinicians, as well as executives from the Department of Health. So it's another example where we've been able to collaboratively cross the divide between the Commonwealth and the state funding system and have clinicians and also consumers involved in the selection process. So this is about shared information, shared decision-making, shared information, connecting our clinicians and our executives across the system. So where do we go now? We can't just have a conversation and come up with motherhood statements and get very excited about it. We have to challenge ourselves and be accountable. And as the chair of the Senate, I'm obsessed about this concept. You've got to demonstrate that you deliver on the investment. And so what we're going to do is we're going to challenge our health services and our PHNs to come back again in October this year and report back on what they've done. So we're going to prepare a report card. We're going to ask every one of the PHNs to fill out a report card back to us. What are the relationships that they have developed with their HHSs that they relate with, and what have they actually achieved as a result of that? So we're going to challenge them around their actual outcomes. And then we're going to start to focus on some of the more micro-level strategies that need to actually be implemented in order to take advantage of those relationships that are building and deliver change. And so we've got to start moving away from the motherhood part of the whole conversation to the actual fine details. So that's probably, I'm not watching my time, but my time is almost exactly up. I have a personal philosophical position around the future of our healthcare and the role of the hospital system in it. I think that our job, the hospital's job, is to support primary care to offer the best care for patients. We're a support service to the main game, and the main game around healthcare for our community rests with primary care. And I think that is a quantum shift in focus from what's happened in the last 2 decades, where hospital care has felt the need to take over, where you send your patient to the hospital for a consultation and never get them back again. I'm a consultant specialist in whatever. The primary care clinicians send the patient for advice on management and treatment, but then the patients need to go back to primary care, to their home, and to get that quality. And I think we've devalued progressively over time the role of primary care, and the hospitals are responsible for that. Now the hospitals need to start to become responsible for changing that focus and shifting it back. It'd be nice to see the government get behind that at the same time. So that's my words of wisdom without any real intellect. And I guess I thought I might. Is there questions? Do I need to open it to questions?
We've got a little bit of time, David. Thank you very much for a terrific presentation, and this is from the PHN team. So thank you very much.
That's very kind. Thank you.
Yeah, just hang on. Colleagues, we've got a couple of minutes for questions or comments. If anyone would like to make one, yes, ma'am. Please, could you stand up and speak loudly for us? Okay.
So you could ask the Minister that. I'm going to say it is fiercely independent. I was appointed by the previous government, and I'm still the chair of the Senate now and have been reappointed to stay on for a little bit longer. I've worked furiously. The value of the Senate is to provide constructive advice. We're not a political lobby body and we're not a professional advocacy body. We are a voice for clinicians around relevant strategic health policy. And if we do that and we don't get involved in the nonsense, then we are particularly valuable to the government of the day, no matter who they are. And so I have been very successful in being able to, although the Senate is funded by the state government, I've broken every rule that there is with regards to being a government organisation. I set up my own Facebook page, I set up my own Twitter account, we have our own media and comms organisation, we have our own website. So we are essentially, if we do our job well, we are totally independent of government.
Fantastic. There's another question down the back. It's a bit difficult if you could speak louder or... Yep. So there are massive cultural and historical attitudes of paranoia and fear that have to become overcome in order for this to happen. I've fought tooth and nail to ensure that this information is open to all primary care. There was a very strong sentiment that only the GP registered to the patient was able to access it. But the vast majority of our patients don't have a GP, they have a practice, or after hours they access whatever service is available. So small steps at a time, this will be open to general practice, but we have absolutely had long discussions that primary care is physio and social work and OT and pharmacy. And it is absolutely on our agenda to ensure that all primary care and private specialists can access this information. I would like the government to take responsibility for negotiating access to this via the PHNs, as you suggest, and we've had this conversation, because what it does is it strengthens the relationship and the value proposition of the PHNs to the primary healthcare practitioners within their local area. So I don't want the government to be responsible for organising access to each individual GP. We want them to negotiate with the PHN, and then the primary healthcare clinicians will come to the PHN to get their access and to register and be responsible. We'll get there. David, thanks very much. That was terrific. Thanks, Dr.